traditionally, payers hear about a rich pipeline like this that involves a bunch of new compounds or a bunch of new molecules, especially some that are biologics, some of which may look like they're about to lead to more combination therapy and have somewhat of a reaction to that. So, but we also have been talking about the needs, the unmet needs here. So I'd like to get the two of you to kind of weigh in on what you've just heard about the pipeline, how you'd be thinking about integrating those into your treatment guidelines, you know, where they'd fit maybe between pharmacy and medical benefit, whatever you think is appropriate. So.
Well, certainly the infusions are probably going to be covered more over on the medical benefit, physician-administered drug program. But we're going to look to partner with providers or the centers of excellence to establish those treatment guidelines and then make sure that we ensure access. One of the other things, and this was to Maria's point earlier, is that there are these new emerging therapies, and we're exploring outcomes-based approaches, that if they're promising a certain result, that we're looking to engage the manufacturer or contract with the manufacturer for those endpoints. And if they don't achieve, then we don't pay the whole price, or we get some type of a rebate back. And certainly CMS is encouraging those approaches.
I think it's exciting, right? It's an exciting time when we have such few options to work with to see potentially the spectrum of additional treatments that are may come to market, including the opportunity even for a cure. Completely agree that with gene therapy, there's great promise, but there's also the need of very new treatments, but the need to assure the durability of the effect, and that indeed, as we sink extraordinary cost, that we are achieving the outcome. So,
yeah. So let's hold that thought and come back to gene therapy for a sec. But let me ask you, like when you're looking at, for example, the first two products we discussed, one of which is pain only, right? The outcome is pain. Do you as a payer view that differently than other sorts of outcomes?
Yes, I think the aspect of disease modification, if you can really change the course of the disease, the complications that ensue, versus just symptomatic management, and also the setting of care, right? I heard that with one of these options, it may be more on the hospital side. At the time that you're already inpatient, you have a vaso-occlusive crisis. And so as a payer, you may not get into the management of what happens inpatient until discharge occurs. And then if it's a chronic therapy, then we typically get involved. So I think also looking at some are IV, some are oral. Obviously the oral's pharmacy benefit, the IV's medical benefit. But I think there's more and more of a concerted effort to manage both medical and pharmacy as we look at what are the options and how do we sequence them. What do we bring together in terms of potential combinations that have different mechanisms of action to really, and maybe even back to the personalization aspect, that really add value to the outcomes.
So say for the sake of argument, the biologic wasn't infused, it was self-injected, but it's pain-based instead of other forms of outcome-based. Do you have a similar response?
Well, we've actually several drugs that are available as an infusion or injection. We actually have covered those in both pharmacy and the medical benefit because there are some smaller providers or providers that don't want to stock or buy and bill that drug, and so we allow it to be provided from a specialty pharmacy or a pharmacy to be sent to the treatment center to be infused or injected that way. So.
And would you assume, obviously we don't know cost of any of this, right? They're all pipeline drugs. But based on what you've heard, do you think specialty pharmacy is a reasonable option in terms of distribution?
I do. I think one of the aspects we're also looking at in terms of controlling medical spend is the site of care. Where can the same agent be infused that hopefully minimizes and maybe even improves compliance if it's convenient for the patient in terms of where they reside, where they can access this, including the home, I would say. But yeah, specialty pharmacy becomes a venue that can drop ship to a physician's office or an infusion center with the goal of hopefully moving to a total lower cost of care.
And sometimes with specialty pharmacy, even the oral agents, they'll have patient programs that are committed to adherence or improving adherence, where they're calling the patient, making sure they're taking their medication, find out if there is any adverse effects, redirecting them to their primary care physician or their treatment prescribing physician for issues rather than showing up or presenting to the ED or the hospital.
So as a clinician, dealing with this population, and you mentioned earlier that your hydroxyurea example, for example, compliance was not what you would like it to be either. Are those sorts of clinical programs pushing adherence and compliance something that you welcome as adjunct, or do you find them to be an interference between your relationship with your patient?
That's a difficult question, but the answer really is that I think that some providers do probably require a little bit of the need to be pushed on the adherence issue. So I think it is helpful to sometimes push that adherence issue, but there are situations where I feel like open lines of communication with this really personalized medicine arena that we're in with this population, open lines of communication are so necessary in really determining the plan for every single patient. Sometimes that becomes the biggest issue, is the lack of communication between the involved parties that are helping determine care for every patient.
And I think that's what we're seeing now is it really is a team approach to the treatment of this disease or any disease, that it can't be siloed, the physician doing his thing and the pharmacy provider doing their thing. It really needs to be a team approach on how we care. That will give the best outcome.
I'd also like to add that you mentioned before the disconnect with the psychosocial. And if that's a gap on your side, yes, how can the payer, through either care management or social workers, be able to integrate with understanding the patient needs? Right. And maybe even the dynamics, because compliance is very personalized. There's many drivers of non-compliance, and unless we really understand that and can then develop solutions to get to that 90% that we're perhaps seeing ex-US, I think is a huge opportunity to work together.
Absolutely.